So today's class is postmenopausal bleeding. So we are going to discuss the process of postmenopausal bleeding, where it is defined as postmenopausal bleeding from, postmenopausal bleeding is defined as any bleeding from the genital tract after 1 year of menopause. So 1 year period of amenorrhea after the age of 40 years is called as menopause. So mainly the cases to be investigated are the patients to be followed up for vaginal bleeding occurring anytime after 6 months of amenorrhea, or even without amenorrhea or irregular bleeding of women after 52 years of age, and where they will be having endometrial hyperplasia and malignancy of the endometrium should be suspected or ruled out. Significance of postmenopausal bleeding is malignancies of the genital tract mainly are cases of concern for postmenopausal bleeding. So malignancies mainly CA endometrium, that is carcinoma endometrium or uterus, and carcinoma cervix, carcinoma ovary, carcinoma vulva and vagina, and sarcoma of the uterus. So what are the benign causes? That is endometrial hyperplasia, endometrial polyp, fibroids, decubitus ulcer, and infections like pyometra, tuberculosis, senile vaginitis, and senile endometritis. So bleeding from the urinary tract and the anal canal also be ruled out because of the hemorrhoids or any malignancies. And irregular intake of HRT also will cause irregular postmenopausal bleeding. So what are the factors which might cause, or the percentage of causes of postmenopausal bleeding? Mainly exogenous estrogen intake will cause 30% of postmenopausal bleeding. Atrophic endometritis and vaginitis will cause 30% causes, and endometrial cancer 15% of cancers, and endometrial or cervical polyps 10% of the bleeding causes, endometrial hyperplasia 5% of the causes, and other miscellaneous causes CA cervix and uterine sarcoma and urethral caruncle, all this will cause 1 to 5% of the bleeding. Next is benign disorders causing postmenopausal bleeding. Mainly HRT, that is hormone replacement therapy, mainly used to treat menopausal symptoms, prevents osteoporosis and bone fractures, which will be given to the postmenopausal women when they complain of the above symptoms like bone pains or any fractures in the bone. So irregular intake of this hormone replacement therapy leads to withdrawal or breakthrough bleeding. So continuous low dose combined estrogens and progesterone resumes the bleeding and will cease after several months. So endometrial hyperplasia and neoplasia is low with this intake of regimes, and endometrial sampling must be taken for any kind of bleeding after HRT. So tamoxifen, which can be given for endometrial polyps and malignancies, and cystic dilatation of the gland occurs with tamoxifen, and it is also causes stromal condensation around the gland and squamous metaplasia around the overlying epithelium. And other causes are atrophic vaginitis and also endometrial and cervical polyps. So main causes of the postmenopausal bleeding here are HRT and drug like tamoxifen, atrophic vaginitis, and endometrial and cervical polyps. These are all benign causes of endometrial, postmenopausal bleeding. So vulval causes, mainly any direct trauma to vulva like labia majora and labia minora, where you see bruising of the vulva leading to hemorrhage, and vulvitis, atrophic vulvitis in case of postmenopausal women, and lack of estrogens in postmenopausal women leads to thinning of the vulva and prone for trauma, ulcerations and bleeding. And benign lesions like Paget's disease, extramammary Paget's disease, where you can see Paget's disease usually seen in the breast, even in the Paget's disease kind of lesion seen in the vulval regions, and erythema, eczema or ulcerations around the vulva, and vulvar intraepithelial neoplasia or carcinoma vulva. All these conditions also lead to postmenopausal bleeding. So when we see for local examination, we have to look for any local lesions. Next is vaginal causes. Ring pessary for prolapse, that is retained and forgotten pessary may cause vaginitis, ulcerations and bleeding and may be a precursor for carcinoma. Next is prolonged retention of IUD when left may cause irregular bleeding or bile matter. Or senile vaginitis due to hypoestrogenic state in postmenopausal women. Atrophic vagina often virulent and blood-tinged discharge. Vagina inflamed whether it is tender and excoriated. And urinary symptoms. In patchy granular vaginitis, the spots of which are red and bleeds easily when swabbed. And may extend upward causing senile endometritis causing bleeding or bile matter. So, in atrophic vaginitis and atrophic menopausal, sometimes you will see postmenopausal bleeding. And vaginal granulation tissue in case of post-hysterectomy, it may cause bleeding. Vaginal ulcerations, usually atresia, tropical tubercular ulcers, also can cause vaginal ulcerations. And vaginal tumors, usually benign and malignant tumors. And post-radiation vaginitis. Postmenopausal bleeding causes through cervix. So, vulva, vagina, followed by bleeding through the cervix. Mainly cervical erosions, chronic infective states, that is squamous epithelium is replaced by columnar epithelium. It is mainly leading to cervical intraepithelial neoplasia and later to CA cervix. So if erosions are present, they are just a replacement of the squamous epithelium by columnar epithelium, which will cause cervical erosion and bleeding. They will have excessive nuclear discharge and also bleeding on touch. So, cervicitis. What is cervicitis? It is seen in menopause where hypoestrogenic state, which is prone for chronic infections, leads to cervical erosions, chronic inflammatory state ulcerations, and presence of contact bleeding. So, we have to treat the cause of cervicitis with antibiotic course, and also we have to do a pap smear to rule out any pre-malignant lesions. Next is polyp. It could be endocervical, ectocervical, secondary to chronic inflammation leading to bleeding and ulcerations. Next is decubitus ulcer in prolapse due to venous congestion may ulcerate and bleed. And other causes are malignancy. So cervical causes are usually cervical erosion, cervical polyps, cervicitis, decubitus ulcer in prolapse, and also malignancies. So endometrial causes, senile endometritis, tubercular endometritis, endometrial hyperplasia mainly due to unopposed estrogens as a part of hormone replacement therapy for menopause. Mainly irregular use of combined estrogen and progesterone will cause breakthrough bleeding, and metabolic syndrome will be resulting in endometrial hyperplasia, and atypical endometrial hyperplasia may lead to carcinoma endometrium. Endometrial polyps arise from the endometrial hyperplasia, some part of the lining protruding into the cavity as polyp, and secondary malignant changes may occur. So, primary malignant polyps, adenomyomous polyps, and also fibroids polyps, and endometrial carcinoma and sarcoma, and mixed mesodermal tumors. So, related to the endometrium, mainly senile endometritis, tubercular endometritis, and endometrial hyperplasia, endometrial polyps, and fibroid polyps, and endometrial carcinoma and sarcoma, and any mesodermal tumors. So, in this, most important cause of postmenopausal bleeding is endometrial hyperplasia. So, here there will be a spectrum of morphological and biological alterations in the endometrial glands and stroma ranging from exaggerated physiological state to carcinoma in situ. So, unopposed estrogen stimulation without progesterone maintenance leads to proliferative endometrium and clinically significant endometrial hyperplasia. So, all this will cause abnormal bleeding associated with estrogen producing ovarian tumors, result from hormonal therapy, and precede or occur simultaneously with endometrial hyperplasia. So, classification by International Society of Gynecological Pathologists depending upon the crowding of the glandular elements. It could be simple hyperplasia or complex hyperplasia. In case of simple hyperplasia, they are dilated cystic glands with round to slightly irregular shapes and an increased granular to stromal ratio without granular crowding and no cytological atopy. Complex is complex crowded glands with less intervening stroma without atopy. An atypical hyperplasia mainly leading to cytological atypia, leading to criteria for cytological atypia: large nuclear variable size and shape, and increased polarity, increased nuclear cytoplasmic ratio with prominent nuclei, and crumpled appearance of the chromatin and parachromatin clearing. All this will cause endometrial glandular changes with cytological atypical changes causing hyperplasia. So simple hyperplasia without atypia, 83% according to the WHO classification. Simple hyperplasia with atypia, 2%. Complex hyperplasia without atypia is 14%. And complex hyperplasia with atypia is 18%. Endometrial adenocarcinoma is 8%. So WHO classification for histopathological percentage occurrence is same this way. This is WHO's classification of endometrial hyperplasia, which will go for progressing into carcinoma. So simple hyperplasia without atypia, 1% of chances of progressing into cancer. Complex hyperplasia without atypia will go into 3% of the carcinoma. And simple hyperplasia with atypia, 8% chances. Complex hyperplasia with atypia, 29% chances. So any hyperplasia with atypia has a larger percentage of chances of going into malignancy. So WHO classification of endometrial hyperplasia will decide the incidence and the cancer risk. So main causes, mainly we have to see for fallopian tube malignancy, which also causes postmenopausal bleeding. Next is ovary, benign ovarian tumors like granulosa cell tumor and theca cell tumors and Brenner tumors. All this will cause postmenopausal bleeding. And any malignant ovarian tumor will cause postmenopausal bleeding. Next is blood dysplasias like factor VIII deficiency and von Willebrand's disease. Next is urinary tract causes, usually urethral current and papilloma of the bladders or carcinoma of the bladder. So bowel causes are mainly bleeding from hemorrhoids, anal fissure, and also cancer related to the large bowel. So all this will cause postmenopausal bleeding. So mainly patient in the 50 to 60 years of age of menopause and estrogen intake history, where you have to ask for tamoxifen intake and any abdominal pain and foul smelling discharge, usually malignant conditions, and urinary and rectal symptoms with abnormal dysuria or any melanoma, and family history of endometrial and ovarian cancers in case of first degree relatives, and general condition with patient with hypertension, where you can see bleeding. So blood pressure examination and also diabetic state of the woman, where the BMI, obese women are more prone for endometrial cancer. And look for embryologic drawing or supraclavicular lymph nodes for malignant lymph nodes. And metastatic nodules in the anterior abdominal wall. And also breast, where you can see gynecological symptoms related to breast cancer. So examination of the patient. You have to see local examination and inspection of the perineum. If uterus is outside the introitus, decubitus ulcer can be detected on the prolapsed uterus. Next is inspection of the vulva, where you will see a growth or ulcerations, where you can need to take a biopsy to rule out vulval cancer. And abdominal palpation reveal tumors or ascites. Mainly suppression of the labia might reveal a urethral caruncle or a polyp or a mucosal prolapse. So mainly it will look for any mass per abdomen associated with postmenopausal bleeding. Most of the time we will see malignant ovarian tumors. Next is speculum examination, where you will reveal an obvious cause in the lower genital tract such as carcinoma cervix, and where you have to go for a pap smear to look whether it is dysplasia or CIN or any stage 3 CIN or going into CS cervix. Next is aspiration cytology from the endometrium by doing a dilatation curettage procedure using a Pipelli curette for endometrial carcinoma. Next is bimanual examination. Uterus may be normal, atrophic or enlarged due to pineal sarcoma. So sometimes you will see even adnexal masses, both infective and also ovarian masses can be palpable. So whenever the patient comes with postmenopausal bleeding, you have to do local examination, you have to do abdominal examination, you have to do post-speculum examination, and you have to do a bimanual per-vaginal examination to rule out the causes from various structures.